Alright, welcome back everyone. I heard y'all liked rap content. You're gonna get a lot more of that. No, don't worry. The anti-epileptics playlist is coming soon. That's like a whole bunch of videos, original content. Don't say I didn't make any original content. But at the same time, we are all Pavlov's dogs, slaves to whatever reinforces better views. And well, you seem to enjoy this at least, so all right, I've decided that given that the last time we did a video react, but I mean, truthfully, the most popular pharmacology resource in the Philippines has to be Katzung's Basic and Clinical Pharmacology. So, I figured, why not make a react video for that? Obviously, I'm not going to react to the whole book because that's a very long book. So let's start with what I'm good at first. Let's start with the neuropsych stuff. Now, of course, disclaimer, I'll be doing a lot of criticism and comments and whatever, but, it might sound like this is bad, but, Professor Katzung, he's a pretty nice guy. We actually talked a bit by email, and I already let him know beforehand all of my concerns. So I have read through Katzung a lot. So I guess it's less of a reaction and more of a commentary, I guess, but I'm still putting react in the full disclosure. The word react is clickbait. The word react is going to be clickbait. So if you're not a fan of that, then I can respect that. Please do check out my less clickbaity videos at least. But for now, I've decided to, since last time we did antipsychotics for the speed pharmacology, this time we'll be doing sedative-hypnotics. And well, I do have a lot to say. This here I am reading through Access Medicine, so definitely you can find this when you check out if your libraries have a subscription. Definitely please do not go to the other websites that you might have been hearing about to get copies of this book. Please don't. Right? So don't. Right. So with that out of the way, let's proceed. All right. So as usual, the start of the chapter, you have the usual case. I won't be showing the whole screen because, of course, I don't want to be just showing the whole chapter. You could just read it here. I'll have this my screen be blocking off most of it. So I'll just be commenting on, reacting to points of interest here. Yeah. So here you see this first part. They talk about an effective sedative or effective anxiolytic. When you say effective, of course, both efficacious and safe. But really, when you look at the wide range of sedative hypnotics we have, some of them, they tend to work. But I do like this quote from, I think it's Professor Rob Howard. The ones that do work, you wish you hadn't started on them. Right? I should have the actual quote here. But anyway, so basically, the ones that actually do work, you'd wish you'd never started on them, because a lot of these come with some serious side effects, especially when given long term. So let me emphasize as early as now that pretty much all these drugs, pretty much all of them, are meant to be short term. Okay, I think it's lost in translation when we teach. There's the idea that these are maintenance meds. No, for the vast majority of people, these should not be maintenance meds. All right. So, yeah, and that will be unfortunately clear as we proceed along. All right. So you have so eventually, they talk about how sedatives at low doses can become hypnotics at other doses. Some have more pronounced effects depending on the dose and so on and so forth. Now we talk about the chemical structures. Okay, talking about the chemical structures, I'll be honest. My OrdMeds foundation is just absolutely bad. It's just really bad. So when I usually talk about the clinical properties of drugs, I tend to skip this because, well, first of all, you have a subject for that already. It's called organic medicinal chemistry. It's a separate subject for it entirely, right? So it'll be redundant to talk about it here. But at the same time, there are people who are just better at working with structures rather than thinking about mechanism to clinical properties. Some people are actually really good at connecting structure to mechanism, and you connect mechanism to the clinical properties. So, for those who are more curious about doing it that route, definitely check out SLRM Chem. Sir Lois's channel has a lot on that, right? But for me, I'll focus more on the mechanism. Yeah. Yeah, so one for blah blah blah. But generally, okay. Now you'll see a lot of other non-benzo drugs here. You'll see a lot of barbiturates. I don't like to talk about them, right? Okay, for the board exam, you might have to study them, sure, but just, I mean, think about how many hours a week you have in class for Picol. Imagine how much you have to cram into that limited time. And you're going to spend that time talking about drugs not available in the Philippines? For shame. For shame. I mean, if it comes out in the board, I always tell my students, like, okay, this will come out in the boards, then study for it for the boards. But because we have just so little time, what I'm going to put out in the exam, I'm going to focus on the drugs we have in the Philippines. And besides, we're not supposed to be giving chloral hydrate anyway. A lot of these, like, like the barbiturates, of course, the barbiturates as a given, chloral hydrate, we generally don't recommend those anymore. The only people who are taking them at the moment, we're like, yeah, I talked about this in the anti-epileptics a bit, are people who have been taking them for decades and are just unable to stop because they're having a hard time stopping, right? But generally, we don't want to start them when we talk about sedation or we talk about anxiolytic effects. No. Okay. And even talking about barbiturates, we only have two in the Philippines. Phenobarbital, used for epilepsy, used for febrile seizures, and refractory status epilepticus. We do not like to use it outside of those, really. And then you have thiopental, used in anesthesia, anesthetics. Outside of those, we do not use that for insomnia. I don't care what the book says. To give credit, of course, to the writing team. The 14th edition, later on down there, they do say something about insomnia, but the 15th edition kind of makes it clear they're not really used anymore, which is better, really, right? So, really, focusing on the drugs you have in the Philippines, it kind of cuts the time that you need to spend on this chapter, right? So, yeah, melatonin agonists would be good to have as alternatives, but we don't have Ramelteon, Tasimelteon, so like, okay, skip, next. Yeah, Zolpidem. We have Zolpidem. So, I do spend some time on Zolpidem. We don't have these others, Zaleplon, Ezopiclone, blah, blah, blah. But we have Zolpidem. So, yeah, we'll talk about that. Okay, so other classes of drugs. Kinetics. Yeah. There's a lot here about kinetics. But really, there's a lot of, I'd say, there's a lot you can trim out here when you start looking through the kinetics. I like to focus on those that have really applicability. So, for instance, when you talk about sedative-hypnotics, very important, half-life and onset of action. So, those are different things, by the way. Okay, half-life, then that kind of is more related to how long the drug will stay in the body, right? And then onset of action, that's how long it takes for the drug to start working. Those are different things, and those have relevance because a drug, particularly a benzo with like a short half-life and a benzo with a quick duration of action but a short half-life. What happens is, remember, these drugs can cause a high. Not for me, I didn't like the benzo experience personally, but for some people, you can experience a high with benzos quickly, but then because the half-life is very short, you just drop down kaagad. And that leaves you wanting more as compared to, say, a slower decline. So, very important to be mindful of the half-life and the duration of action here. Those are the important kinetic parameters, really. In terms of metabolism, yeah, you'll hear about the mnemonic lot, which is the drugs that you can safely give to people with hepatic impairment because they bypass CYP enzyme metabolism. They go straight to They go straight to conjugation and excretion and all that. Basically not much liver metabolism. But I did ask some psychopharmacologists during our British Association of Psychopharmacology training. So I asked them, what happens if you don't have lorazepam, oxazepam, temazepam? We don't have those in the Philippines, actually. What do you do if the patient has hepatic impairment? And what they did say was very enlightening from a clinical perspective. Don't force yourself to use a benzo you're not familiar with just because the book and the guidelines say Okay, use these if the patient has hepatic impairment. What is actually safer for the patient is you use a drug, that a benzo that you are more familiar with, and you adjust the dose accordingly for hepatic impairment. Because if you're not familiar with the drug, the dosing, the kinetics, and you just jump into it because, okay, book says it's safer, the patient is going to have a harder time. Versus if you're familiar with the drug. We were talking about in the context of alcohol withdrawal, but I guess the same can be said in general, because in patients with hepatic impairment. Lalo na ngayon, again, we don't have lorazepam, oxazepam, temazepam. So like, right? Okay. Now, so there's this diagram, this very famous diagram. I have a version of this diagram in my cheat sheet. I should totally flash this, but I don't want to edit this video anymore, so whatever. This diagram does show a lot of the benzos, but again, which of these are actually relevant for us to remember in practice, right? So sige, using this diagram, you have diazepam for sure. It's a classic diazepam. I'll start with the PNF ones. Diazepam. Remember diazepam. Remember lorazepam. Diazepam, lorazepam, alprazolam. Yeah, in this diagram, the only ones that are relevant in the formulary, diazepam, alprazolam, lorazepam. Clorazepate is available in the Philippines but wala siya sa formulary. And yung wala dito, yung kulang na nasa formulary, bromazepam, clonazepam. So, yeah. All the rest, that's all trivia. But if your exams contain trivia, you'll have to study the trivia, right? That's just not relevant to us. But yes. Tables. Okay, there's a table for kinetic profiles. So check that out. What's a table got to say here? Our internet is lagging because of the... It's gonna take a while. Let's just go back to that later. But again, like I said, remember onset of action and remember half-life. Those will, that will influence your choice of agent. Buspirone, skip. We don't have that in the Philippines. We can totally skip that. Barbiturates, again, phenobarb, thiopental, the rest we can skip. And in your hypnotics, just Zolpidem. Just Zolpidem, right? Just Zolpidem. That's it. Yeah, all of this, the rest, yeah, I mentioned the important stuff. So, there's really nothing much to talk about. I don't care about perprobamate, really. Blah, 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 blah. Yeah, the GABA receptor, definitely, that's usually... it can help you understand how the MOA works. So, I do say there's still some relevance in learning about the GABA receptor, having the 5 subunits, forming the ion channel, and how phenobarbital will differ in its MOA as compared to benzos. So, phenobarbital, tal as in tagal. Pinapatagal niya yung pagbukaka ng GABA-A receptor mo. Let me use my left hand there. So, longer opening. It goes inside the ion channel and it prolongs. So, tagal, tagal. As compared to benzos, BEEG, pinapalaki niya. Bigger opening of the ion channel for chloride to go in. Then chloride will then lead to CNS depression within the neuron. And then yun. But of course, because of the differences in MOA, we generally like phenobarbital less. We don't like it that much, actually. So, benzos, Zolpidem are the preferred. So, in the Philippines, it's really the benzos that we have, and we only have a few of them. Alprazolam, bromazepam, clonazepam, diazepam, midazolam, and clorazepate. Those are the 6 benzos we have. And then you have Zolpidem. That's it. Oh, okay, fine, and melatonin. But melatonin it's really weak. It's very weak. Okay, it's very weak. Yeah. Okay. So, this is fluff. This is very detailed fluff. But again, with limited time, I tend to not focus on that too much. So, yeah, they have specific binding sites. But yeah, flumazenil, something I want to highlight in. Flumazenil, just remember that when you're reversing, with benzotoxicity, when you're reversing benzo binding to the GABA receptors, you're also reversing its efficacy. So if you're using the benzos for seizures, flumazenil, as an inverse agonist in the GABA-A receptor, might provoke seizures, actually. So not saying don't use it, but rather be careful, right? More be careful, really. Yeah, chloride channel, blah blah blah. I don't care about these other drugs. So yeah, that's another thing. Other GABAergic drugs like thiagabine, vigabatrin, we're not really a big fan of them because they've either been withdrawn. I think if thiagabine withdrawn, I have to double check, or they have serious side effects. Yeah. So blah blah blah. Or so the effects are generally sedation, sedative-hypnotics, sedation, but don't be surprised if you see side effects in like other areas like the GAT because GABA receptors can pop up in surprising places. So while the main effect is sedation due to that's the alpha 1 receptor, alpha 2 and 3, sorry, not alpha 1 receptor, the alpha 1 subunit of the GABA-A receptor, then you have the alpha 2, 3 subunit of the GABA-A receptor for the anxiolytic effect, alpha 5 receptor, anterograde amnesia, right? But then there are also GABA-A receptors in other areas. And if you as positive allosteric modulators, enhancing GABA effect at these receptors in the other areas, GABA being an inhibitory neurotransmitter, it may lead to inhibition of functions in other areas then. So sedation, hypnosis, that's kind of a given. Blah, 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 blah. Generally, we don't see differences in efficacy. There was a recent network meta-analysis wherein, again, generally the drugs that work, they're not the ones you really, really, really want to start people on. So, benzos work, Zolpidem works, but long term, they do have side effects. The addiction, dependence, the therapeutic index, right? Especially when you add them on with multiple CNS depressants and anterograde amnesia, which is not good if you're going to therapy. Because anterograde amnesia, what that means is you forget what you learn. And in therapy, the way it works is you're learning. So benzos plus therapy generally not a good combo. So you don't want to do that long term. Anesthesia, that's benzos can be used also. I do not know much about anesthesia to comment on it to think about it too much. But thiopental, that's the barbiturate you commonly see used as an anesthetic. Yeah. Anticonvulsants, so again, mainly for refractory status epilepticus. So it says here, let me see what they say about phenobarb. So phenobarb and not available in the Philippines are effective. Yes. Okay, so again, phenobarb is effective. Yes. But please do not use it if there are other agents you can use. Okay, if it's a febrile seizure, sure. But generalized tonic-clonic, for instance. So there. Although not the first line, very important. It is not the first line. Okay, if you're talking about generalized, valproate is your first line. A lot safer. Okay, so just don't. Okay, don't phenobarb, please. Zolpidem would be mainly an alpha 1 subunit specific GABA-A receptor agonist. So mainly for the sedation, less for the epilepsy, really. Muscle relaxation, they may have muscle relaxing properties, but I don't see them used as often there. Or maybe that might be more of when you venture into the anesthesia part. But anyway, that's not my forte, so I can't talk about that too much. This one. So, respiratory depression. I think the Midnight Gospel, episode 1, I think it's on Netflix, they do a very good summary of what happens when you pile on drug after drug that can, again, depress the central nervous system. We actually call that the Holy Trinity. When you pile a benzo, an opioid, because opioids can also depress the CNS, and skeletal muscle relaxant, like cyclobenzapine or orphanadrine. That's called the Holy Trinity. Please do not. Okay, do not pile on those three. Because that has led to a lot of cases of really, really bad CNS depression, even extreme cases for respiratory. So just don't. Okay, don't pile on. Okay, so let's see how they do tolerance. So again, I've read these, but I haven't. But it's been a while, so let's see tolerance. Decrease responsiveness to a drug following repeated exposure. Yeah, that's right. So you would need higher and higher. This is particularly for the sedative use. So I know to emphasize, there is no tolerance for the anxiolytic use. Okay, so when you say tolerance, you need higher and higher doses to get the same efficacy, because at your standard dose, nawawala yung efficacy due to changes in the receptor density, etc. So what happens is you need to keep escalating the dose. Nagiging tolerant ka na sa effects niya. Yan. That only happens for the sedation. So you eventually need higher and higher and higher doses. What ends up happening is the person ends up stopping, they go into withdrawal, and then, after a period of benzo-free or sedative-free, they start again on that very high dose they were maintaining on without giving their body time to adjust, to develop tolerance. So what happens is, bam, CNS depression. Okay, so that's another reason we're not really a big fan of long-term benzo use talaga. Okay? These would really be mainly short-term agents. So, tolerance, that is the one feature of dependence. So, this is the part where it gets confusing. You have psychological, physiologic dependence. Depending on the country you're in, the word dependence may connote different things. Dependence may be both psychological and physiological for some people, and then for others, it may just be physiologic. So I do like how the British Association of Psychopharmacology approached this. It just focused on the pharmacologic definition of dependence, which is yung physiologic. When you say physiologic dependence, I need to keep taking it because physically, if I stop, I will experience a very painful set of withdrawal symptoms. Very distressing, very unpleasant, very painful. So that's dependence from a pharmacologic perspective. Psychological dependence, that's more of the addiction na. Those are distinct concepts, okay? So in the US, we make a distinction between addiction and dependence. In the UK, it's a bit conflated-ish. So we'll just stick to the pharmacologic definitions na lang in this case, right? So, yes, that's the reason we don't want to keep using this very long. Not just for insomnia, but also for anxiety disorders. Because many people with anxiety disorders, they also end up having a hard time sleeping. And then, the tolerance problems with addiction, dependence. So not very good for long term for most people. Okay, so So flumazenil, we mentioned flumazenil, blah blah blah, so on. Okay, clinical pharmacology. Here we go. So the 14th edition has ways to go in this section, really. So let's see how they went about it here. So anxiety, by the way, I just want to remind everyone, anxiety is normal. Anxiety is a human emotion. It's like sadness, it's like joy, it's like inside out. So there should actually be another emotion there named anxiety, but they label it fear. There are different things actually. But anyway, it's a normal human emotion. What's not normal is if it becomes out of proportion, it starts affecting your quality of life. That's something you might need meds and or therapy for. But again, we don't want to be doing this long term. Let's see if I can open the tables now. Or is it not loading? I don't think it's loading for me. Okay, so last I checked, these tables mentioned, anxiety disorders. Sure. Oh, it did not load this. Okay, anyway. But again, I must emphasize, short-term usage. I know there are European College of Neuropsychopharmacology articles out there arguing that yes, you should be using benzos long-term. Yes, a randomized controlled trials. But let me remind everyone again that the therapeutic index for benzos is a lot narrower than, say, SSRIs. These are not drugs you should be taking lightly. Okay. For those who are on benzos, I'm not trying to scare you, because what happens is, please do not stop, change, adjust your meds when you hear about these things, because if you suddenly stop, again, withdrawal will happen. So if you have concerns, definitely talk to your doctor. But this is a message to health professionals and up-and-coming health professionals. Please do not adjust. Do not recommend these long-term. Okay. Generally, I defer to Dr. Tyler Black, the golden concept. These are short-term meds. When you start them, you should already have an exit plan. Kumbaga, the moment you prescribe or you recommend it, dapat may kaakibat ng stopping plan. Because again, these are short-term meds. Okay. So generally, I also want to emphasize that these are only useful in the anxiolytic part for anxiety disorders, as in generalized anxiety disorder, panic disorder, social anxiety disorder. They are not useful for OCD, even though OCD is not an anxiety disorder. Okay, they're not useful for OCD, and they are contraindicated in PTSD. Because in the past, PTSD used to be an anxiety disorder, but now it's its own category. But again, contraindicated in PTSD. But it's still prescribed. Yes, we generally don't recommend it. Okay, we don't recommend it talaga. Because again, anterograde amnesia will prevent you from learning that your traumas are now over and the thing that happened to you in the past is done. How can you learn that if you're on a benzo, right? Kind of hard. So yeah. Orexin, unfortunately, there's a lot of buzz about the orexin receptor antagonists like suvorexant, because orexin, hypocretin, these are wake-promoting neurotransmitters. You antagonize those, helpful for insomnia, but unfortunately, we don't have those, so I can't really talk much about them, or I couldn't care much. I wish we had them, more options, but okay. So again, with appropriate caution, definitely. Okay. Notice here, that does not impair motor function or cognitive function during waking hours. This is where half-life comes in. This might be where we prefer Z drugs, Zolpidem, to Benzos, because Benzos generally have a longer half-life. The Benzo half-life is generally about just 7 hours. The Zolpidem half-life is just about 7 hours-ish. So it'll last shorter. Daytime sedation can still happen, but in theory, it might not be as long, right? But of course, the caveat there is you want to make sure the person can get like 7 hours of sleep. Sorry, was the half-life 7 hours or was the sleep you need? Sorry, I have to double check the half-life. Okay, but generally you want to make sure you get at least 7 hours of sleep when you give Zolpidem. I don't think it's mentioned here, but it should be, because if you take Zolpidem and you set an alarm that in like 4, 5, 6 hours, you are not gonna wake up. So make sure you have enough time to sleep if you're gonna be taking drugs like Zolpidem, right? Anyway, it should be as needed lang naman. Hindi naman talaga siya dapat maintenance, right? Blah blah blah. They can disrupt sleep architecture. Yeah. But okay, to be fair, I used to harp on and on about this. They can disrupt sleep architecture. But to be fair, it is true. I learned this in Aston. We do not know if the disruption in sleep architecture translates into something happening to the patient. We don't know. Okay, we don't know. What I do know is we still prefer psychotherapy, CBTI. That's still first line. That is always first line for difficulty sleeping. But yeah, you really gotta watch out for the daytime sedation and all. They didn't mention the thing about, with Z drugs that you need 7 hours. They really should mention it here. They should. And the sleep problems. Oh, the sleep problems. Sleepwalking, sleep phone calls, sleep sex, abnormal sleep behaviors. That can happen with benzos, but it's been a boxed warning, particularly for Zolpidem. So, Z drugs in general. So, warn about that. Yeah, warn about that. Particularly for the people living with a service user taking the Z drug. Right, so blah, blah, blah. Suvorexant. Yeah. Again, short term. Don't care about this. We don't have the probramate. So yeah, you see, I get to really that's what I love about knowing what drugs we have in the Philippines. Knowing what actually happens in practice means we can focus, right? So for PICOL in the curriculum, that's more a clinical subject. You have the drug discovery stuff and the drug discovery and development and ORGMED. So I can focus. You can use the time effectively. I don't cram all that discussion into just a very short amount of time at the expense of other drugs, right? Because you know what happens in actual practice, right? So again, for toxicity, again, avoid the Holy Trinity. Do not stack CNS depressing drugs. Of course, check driving. Those who drive, operate heavy machinery, you might give them a heads up, because the daytime sedation with these drugs, because they have because the benzos, they have long half-lives, they can impair driving and operating machinery in the morning. So yeah, Then anterograde amnesia. Yes. 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 Not yes, it's utilized for procedures like in anesthesia as part of as adjuvant and anesthesia, but in psychotherapy, this is harmful. This is why this is contraindicated in PTSD. We don't like it in PTSD because of this. Exactly because of this. Yeah. Okay. Yeah, definitely mindful in the elderly. Because in the elderly, the extra problem there is falls or fractures. If you get sleepy, you get dizzy, you fall down the stairs, you fall on a hard surface, you hit something, fracture, infection, so on, so on, so on. So kind of extra precaution. Extra precaution there. So, eto pa. Again, very narrow therapeutic index. So why do you want to be giving this long term? Don't. Okay? Just want to avoid giving it long term. Okay? Just want to avoid giving it long term. Right. So blah, 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 blah. Yeah. We don't really use dopamine a lot. Or maybe, probably people practicing in emergency medicine, or can chime in there. I hear dobutamine a lot more and less of dopamine. But, sorry, for inotropics, yeah, less of dopamine, more of, I hear more dobutamine, isoproterenol, etc. Okay, now flumazenil, yeah. Yeah, so controversial. See, again, it can precipitate, well, maybe one reason is it can precipitate seizures. Because that's the opposite of GABA. Don't care about the other benzos. You can skip those. Pregnancy. Yeah. Alterations in drug response. Yeah. Cross tolerance. Again, regardless of which sedative-hypnotic, I cannot say this enough. Short-term use only. Preferably nga 7 days eh. I mean, some will say 2 weeks, fine. Pero, okay, to be fair, in the 15th edition of Katzung, they do say na 1 month. But I feel like 1 month is too lenient. I feel like dapat 2 weeks lang. No, sorry. Actually, the 15th edition says 2 months. And 2 months, sobra na yung 2 months. Sobra na yung 2 months. It should be no more than 2 to 4 weeks. 4 weeks is kind of pushing it already. So, no more than 2 to 4 weeks. Ideally nga, no more than 7 days eh. But if it has to be taken for longer, kung sana ma-emphasize as needed. See, again, the mainstay here is CBT for insomnia. Okay, you should be doing therapy for this. And technically, psychiatrists and even some physicians, non-specialized physicians, are knowledgeable about this. I just wish it were taught more. Because I have heard that certain healthcare institutions, they do not teach CBTI as much. They should. So, interactions, some CYP, CNS depression. So, to sum it up, right? There's a lot being said here, but basically CYP, some of them CYP, some CNS depression. Yeah, okay. I did see a study tip on Twitter that for Katzung, you probably wanna focus on the summary if you're pressed on time. So let's check out this summary table. Let's see what they say. So again, very important to know the half-lives individual. It's not in the summary table. It should be. It should be in the summary table, no? So again, there we go. I like this. Acute. Okay, not maintenance. Acute. For majority of people, acute. A small fraction may need maintenance. Very small. Generally, acute. Okay? Acute. Short-term sleep. Oh, there is one indication that's missing here. Very important indication that's missing. Catatonia. Grabe daw. There was what was that called? The something bed sign. How do you know a patient with catatonia has gotten better from the benzo when you can't find them in the bed because they've actually gotten out of the bed? Like that's how, like for people that with really bad catatonia, some people end up like not be able to move at all, even lying in their own excrement. Benzos can help. If that doesn't work, that's where ECT can come in. But yeah, lorazepam specifically can play a role in catatonia. Unfortunately, we don't have lorazepams. I don't know what we use here for catatonia. I have to ask. No? So if you know what's being used in the Philippines for catatonia, please comment below. I'd love to hear it, actually. because I don't get much inpatient experience. I don't have inpatient experience because no opportunities in the Philippines. It's all just community-based that I get. So, yeah, do let me know. So, again, what do we have in the Philippines? Alprazolam. Walang bromazepam because bromazepam is European, but we have bromazepam in the Philippines. Alprazolam, missing bromazepam, so we have bromazepam. We don't have this. We have flunacepam, we have flurazepate, you have diazepam. Walang esazolam, walang flurazepam, walang lorazepam. We have midazolam. Yeah, we have midazolam. No oxazepam, no quazepam, no temazepam, no triazolam. See? Save so much time kasi half the drugs, wala. Flumazenil, I don't know if we have the antidote actually. We should have in theory. I have to check the FDA website. Now, barbiturates. So, phenobarb. Tapos, and thiopental. The rest, I could care less. So again, tagal. So, duration. Tagal. Benzo, BEEG. Increased opening frequency. So, bigger talaga. Let's see. Newer hypnotics. Blah, blah, blah. Zolpidem only. We don't have the rest. We don't have this. So, yeah. Right? Yuck brand names. I have to cut that out. I wish I could, but I'm not editing this. So, yeah. Right? That's it. You can go through all of that quickly if you really know what's happening in practice, what we actually have, right? What we actually use, what we should not be using, right? It makes things so much less complicated, you know? And then you can just segregate the rest as trivia for the boards maybe or for your exam. So, I don't know. For me, it's like a useful memory aid to know what's actually being done in practice. And then I can just organize the info like that, you know? Right. And so that's it. That's how I feel, how I'm reacting to this chapter. Let me know if you're enjoying this series so far. If you are, I'll make more videos. If this doesn't get as much views, then, I can stop. Because I really do prefer original content. But if you do like the react videos, do let me know. And, we'll send more your way, right? And with that, Jarvin out.